as a part or as a total.
Yes, so please, I think we can start for now.
Perfect. Then first slide, please. So if we talk about adhesions, then it's always a thing that has got something to do with the trauma. So if you look at those slides that you see there is some trauma on the peritoneum, and due to this trauma, there is fibrin like a glue, a body glue that brings together, that let organs stick together that normally are not glued together. So this means that you have a trauma, you have fibrin, and you have a gluing together of the peritoneum and some organ. And then afterwards, the body starts healing, and at the end, there is a normal situation again with free peritoneum, or there is an adhesion that is a sequel, that is a rest of this healing process. Next slide, please. And there are a lot of molecules, a lot of different products that are, well, taking into account that adhesions are occurring. And on all those levels, there is a possibility to do something against adhesion formation. And during the lecture, we will talk about the different possibilities we have to interfere with adhesion formation. Next slide, please. The problem is that, next slide. Yes, so the problem is that at the one hand, every surgery you do, you provoke adhesions. This is the one hand. The problem that due to your surgery, you make adhesions. And this has got nothing to do with gynecology or abdominal surgery. This has got to do with every surgery. Let's talk about cardiac surgery, orthopedic surgery, thoracic surgery, ophthalmologic surgery, and even in animals. You always have the same problem that if you provoke a trauma, you provoke adhesions. And you really don't know what will be the amount of adhesions that will occur in a patient, because this is depending on the biophysical profile, the biogenetical profile of this patient. And we don't have biobanks for adhesion formation. So there is only one thinking that can be in the mind of the surgeon. This is, if I am doing surgery, there is a risk of adhesion formation, and I really don't know if this patient will have a little bit of adhesions or will have massive adhesions after my surgery. So this means that even the same surgeon is doing the same surgical technique with the same disease in the same operating theater, there can be a huge difference in adhesion formation differing between the different patients you are taking care of. And this because of the biogenetical profile of the patients. Next slide, please. And there is a lot of adhesions coming, a lot of adhesions coming. And the problem is that it's coming with every surgery you are doing. Of course, the amount of surgery you're doing, the trauma you're putting, is giving you another risk of adhesion formation. We will talk about this later on. But there is no surgery where you can say, I will have no adhesion formation. Next slide, please. And there are, of course, surgeries that are at high risk. For example, uterine surgery, like myoma enucleation, or tubal surgery, ovarian surgery, endometriosis surgery, And of course, adhesiolysis, because if you do adhesiolysis, this means you are doing surgery on a patient that is already prone to develop adhesions. Otherwise, this person would not have adhesions. So she is already at risk. Next slide, please. And the significance is, of course, huge, not only for the patient. The patient can have chronic pain afterwards due to the adhesions. The patient can have infertility or even bowel obstruction. The surgeons, well, if you go in again after a surgery you have already done, and you do a second surgery, the amount of complications you have and the time you need to do the surgery is higher because of the adhesions. And this, of course, brings a higher cost to the community, to the health insurance, to the government. Next slide, please. Another problem is that adhesions, you don't really always know if somebody has adhesions. So it can be that somebody has adhesions and the problems only come many years afterwards. So first of all, we have to know that the building of the adhesions starts at the moment where you start your surgery, and it stops around 1 week after your surgery. After this time, there is no new adhesion formation due to this surgery. So this means you start your surgery and 1 week later it's completed. But the density of the adhesions can change, and also the influence on the surrounding organs can change. For example, the bowel can have an obstruction also 1 year, 10 years, 20 years after your primary surgery. So if you look, for example, after an appendicectomy, you have a lifetime risk of 5%, so 1 in 20, to have some kind of bowel problem during the lifetime. And this is a linear risk. So it's not only occurring in the first year. You can have a bowel obstruction due to an adhesion 20 years after your appendicectomy. Next slide, please. So now we come to the first block after this small introduction. The first part is, what is the past? The past is that you cannot do anything against adhesions if you don't have a good surgical technique. And the good surgical technique means, like Metapan already said, you have to reduce the trauma to your peritoneum. So this means that you have to try to have not too high a pressure in the peritoneum. You have to try to avoid desiccation of the peritoneum, drying of the tissues. And this you can do, for example, by continuous irrigation. Also the sutures. Many people think the sutures you use should be resorbable sutures because they go away quickly. The problem for the body is that to resorb the resorbable sutures, there must be a higher activity in the body, and this higher activity gives you more adhesions. So at the end, the non-resorbables have less body reaction and thereby less adhesion formation. Of course, it is clear that the smaller the sutures you use and the thinner the sutures are, and the lesser you use sutures, the better for the body, because the body reaction is lower than if you suture a lot and you use very thick material and you use a lot of resorbable sutures. Also, all the foreign bodies you bring inside and you don't cover them, like the meshes, for example, you don't cover them with peritoneum, you have the problem, there is a higher adhesion formation because the foreign body is lying free in the abdomen, and by lying free, it's reachable for the other organs that can glue to the foreign bodies. Also, the starch you have on gloves not so many countries still have starch gloves, is a foreign body and can provoke adhesions. Next slide, please. So this means that one strong pillar of the adhesion prophylaxis in the past, and still true for today, is tender loving care of the peritoneum, good surgical technique. Also, there are some products that are already very old that have been tried to reduce the adhesion formation with, for example, antibiotics. The antibiotics are working as an adhesion prophylactic agent when you use them to avoid an infection. Because if you have a trauma and you have infection, then the amount of adhesions is much higher. So this means that if you can avoid an infection, then you can avoid adhesion formation. Thereby, it could be that antibiotics avoid adhesions, but not by working on the adhesions, but by avoiding the infection. You can reduce the body reaction, for example, by corticosteroids. Some people at the end of the surgery, they put into the abdomen corticosteroids in a solution. This is also working because you are reducing the body reaction. By reducing the body reaction, you reduce adhesion formation. But you have to be careful because the corticosteroids also reduce the body reaction to bacteria. So it could be that if you put corticosteroids in the body, in the abdomen, that you have less adhesions, but on the other hand, you could have a septical problem afterwards, and you could have no adhesions, but you lose your patient due to a septical problem. Fibrinolytics is very interesting because this could be something for the future. If, like I said before, the problem is the glue that brings together the peritoneum with the trauma, and this glue consists out of fibrin. So if you have fibrinolytics, like TPA, for example, then you would reduce the fibrin formation. And if you reduce the fibrin formation, you will reduce the adhesion formation. The problem there is that also the clotting system in the body is using fibrin to provoke a blood-free healing. So at the moment where you bring in fibrinolytic activity or fibrinolytic drugs, you reduce adhesion formation, but you also reduce your clotting. So you could provoke a bleeding. Next slide, please. So this was, let's say, the past. But the past doesn't mean bad. The past means this is everything you can do right now. You don't have to wait till you have a budget with a lot of money. You don't have to wait for guidelines. This is an own standard you can apply, and this standard is still active. This standard is still up to date because there is no good surgery when you are not taking care of your peritoneum and you are not continuously reducing the trauma to your peritoneum. So now we come to the present, not to the future, to the present. To the present, there are adhesion prophylactic agents, and there are three big groups. The first group is put some shield between the trauma, the field of trauma, the area of trauma, and the organs you want to save, you want to take out of the adhesion formation area. And this you can do with some kind of shield you put in between. And this shield can be a resorbable shield or a non-resorbable shield. The resorbable shields are made of a sort of cellulose. The non-resorbable are in fact plastic sheets. The problem there is that you have to remove them after your surgery. The second possibility is a gel. The gel is covering your wound, and by covering the wound, there is a distance between the traumatized peritoneum and the organs that cannot reach the trauma, and thereby you cannot have an adhesion formation. The third possibility in the part of present is the fluid. Fluid you put in after your surgery and you leave it inside, and the goal is to make a dilution of the bad products, the products like the cytokines and the prostaglandins that provoke the adhesion formation. And at the same time, you keep hydroflotation. This means you keep movement in the body, and due to this movement, there is also less gluing. Let's talk about a few of those possibilities. Please. Next slide, please. Next slide. Next slide. Next slide, please. Yeah. So, next slide, Olaric. No, this is too far. We have to have the slide. Adhesions, a biotechnological danger. I think it's the, yes, this one. Perfect. So, there are only a few products, and you should not try to read it, because this is not the goal. The goal is that we want to show you there are a lot of products on the market. The problem with most of the products is that they are expensive, so you have to have some kind of budget given to you by the health insurance or given to you by the government, or you have to have a backup by the scientific societies to implement them in your thinking. In some countries, the patients pay extra. In some countries, it's the government. In some countries, the health insurance. In some countries, there is no budget for those products. So the problem is that we need more acceptance for this problem, and the acceptance can only come through awareness and a good quality of scientific studies. Next slide, please. So one of the possibilities is some kind of shield, like we said before, and this shield can be made of cellulose. You put it inside, it stays inside for around 1 week, and afterwards it is eaten up by the body. But in this time, the peritoneum has already healed, so the adhesion formation rate is less. The same thing you can have, for example, with a Gore-Tex membrane. The problem there is that after 1 week, you have to take it out. You have to do your re-laparoscopy to take it out. And this is, of course, not nice for the surgeon, not nice for the patient. And taking it out could provoke another trauma to the peritoneum. Next slide, please. Next one. So then you have the gels. The gels are like toothpaste. They are in a syringe. You bring it through, out of an ampulla, through the syringe, in to your abdominal cavity, and you bring it. Alright, you can still hear us?
Yes, I can hear you.
I can continue?
Sure, please.
Okay, so the next possibility are, as said before, the gels. The gel is like a sort of toothpaste. You bring it into the abdomen through a syringe. You put it at the place of the trauma. And then afterwards, it is covering the trauma for 3 to 5 to up to 7 days, and thereby avoiding that other organs adhere, glue to the peritoneum. Next slide, please. Then there is a product that can be used as a powder. This is interesting because if you use this powder and you spray this powder on the place you are doing your adhesion prophylaxis, there is also an hemostatic effect. So this means that, for example, if you are doing surgery on an endometrioma, everybody knows that if you are doing a complete ripping out of the cyst wall, a complete extirpation of the cyst wall, there is very often, next slide please, there is very often a wound in the ovary. So if you, like the Escher and ASRM say, the gold standard, if you do surgery on an endometrioma, is to take out the whole of the cyst wall. Then, if you do this, you make a wound in the ovary. And this wound you cannot coagulate, because if you are coagulating this wound, then you are killing the ovary, and afterwards the endometrioma is gone, but also the ovary is not functional anymore. So one of the possibilities there is to use this powder to spray it inside of the ovarian wound you made, and then afterwards, after you reach the hemostatic, the hemostyptic effect, there is also an adhesion prophylactic effect. Next slide, please. So the next one is, for example, is an example of the fluid. The fluid is some fluid that must stay in the abdomen for a few days. Because if you are using Ringer's lactate, it stays in the abdomen for 12 to 24 hours, not longer. You can check this with a vaginal sonography. After 24 hours, it's nearly completely gone. So you need something that stays longer in the abdomen. And this is, for example, ecodextrin. Ecodextrin you put in when you finish your surgery, 1.5 liters. And even after 3 to 4 days, you can still see ecodextrin in the abdomen. Not the 1.5 liters, but a lot of the product is still there. So at least 200 to 300 ml is still there from 1.5 liters if you check after 3 days. So these are the three, next slide please, the three possibilities that you have in present to take care as an extra to the past with the tender loving care, the good surgical technique, the present that takes care of an extra you can do, namely adhesion prophylactic agents. As a go-in-between, before we go to the future, a few thoughts. Key message to the patients. It, of course, depends on what you are planning to do. If you do an extensive endometriosis surgical treatment, the chance of having adhesions is very, very high. If you're only doing a plain, easy cystectomy, the chance of having an adhesion formation is much less. So, key message is, as long as we don't have biogenetical profiles and we know exactly which patients are really in need of adhesion prophylactic agents, at least we should think of the situation where we should really think of implementing an adhesion prophylactic agent. The next thing is, don't ever forget your good surgical technique, because some people think they have an adhesion prophylactic agent, then it's not so important anymore to do good surgery. We should also not forget, next slide please, that there is an adhesion prophylactic problem as well in laparoscopic surgery as in open surgery. So to say that there is a higher rate of adhesion formation in laparotomy, this is correct. The laparotomy has a higher adhesion rate as the laparoscopy, but in reverse, you cannot say, I do laparoscopic surgery, then I don't have adhesion formation. This is wrong. Also, in laparoscopic surgery, you have adhesion formation. The problem is that people who are interested in adhesion and adhesion formation, they are usually the people who are doing a lot of laparoscopic surgery and who are doing a good surgical technique. And there are a lot of people who say, well, listen, adhesions, well, this exists, they exist, but we cannot do anything against it. And very often those people are not taking care of the peritoneum because they say it's, well, it's fate, you cannot change it. So always when I'm talking about adhesions, the people that are listening are people that are already having their own standards and already thinking about adhesions. And this is, of course, a problem because this is not the good audience. We should talk to the people who are not interested in adhesions. But it's, of course, not so easy. Next slide, please. So, and we see that over the years, always more and more people, when we do a survey, always more and more people are interested in adhesions and are interested in how to take care of adhesion formations. So, a few messages before we go to the future, a few messages for the gynecologists. The first thing is awareness. Accept that even if you think you are a good surgeon, and even if you think you are doing everything you can, accept that every time you do surgery, there is a risk of having adhesion formation. And when you have this in your mind, then this will always follow you. And then you will say, for example, if I need a towel, let's take a wet towel, if I need one. And if I need coagulation, let's do the coagulation, but please don't do too much, because if we do too much coagulation, then we will have a trauma too big. And if I do a surgery, do I really have to do all the steps? Or can I, for example, reduce surgical steps, thereby reducing the trauma? Next slide, please. And of course, we should talk to the patients and say, if we do this kind of surgery, the risk of having adhesions is higher, but I am taking care of you and I will try to have less adhesions. Next slide, please. And of course, research. We need more research, and we need the companies, the industry, to be able to help us to do more research and to give us products, to test those products and to see which products are really of benefit for our patients. Next slide, please. Before we come to the future, some risk score. We just published together with Richard and Brooke a nice publication last week concerning a risk score. And this is the risk score of the European Society, where we have some data to put patients into low, medium, or high risk, depending on the anamnesis, depending on their history, depending on their disease, and depending on the surgery you are doing right now. Next slide, please. So if you look, this is again very small, but it's just to give you an idea. A lot of topics are brought into the risk score, and with every topic you get some kind of point, and with those points you can calculate the risk score that this patient will have, depending on the history this patient has, depending on the disease the patient has, and depending on the present surgery you are doing. Next slide, please. Next one. Next one. So now we go to the slide that is starting with peritoneal full conditioning, Olarik. Peritoneal full conditioning. There is a red There is a red stripe at the
number 29.
The number 29. Yes, that's it. So we come to the future. The future, let's go back in mind to the first slide. The first slide said that there is a lot of, I think, no. Go back one slide, Ulrich. Yeah, and leave it there, please. Don't move. So we think back to the beginning of the lecture. We said that to have adhesion formation, we have a lot of products that are working. A lot of products like fibrin and fibrinolysis, like cytokines, like prostaglandins, like all kind of cellular influence, like mesothelial cells, like white blood cells. They are all somewhere working on adhesion formation. So the future could be that we influence metabolically on the place where is the trauma. So one of those thoughts is the theory of Philip Konings that says, let's try to influence the metabolism at the place of the trauma, thereby avoiding the cascade that makes the adhesion formation. And he says, for example, using oxygen or using N2O reduces the trauma to the mesothelial cells, the trauma that is provoked by the CO2, it reduces it, and thereby it doesn't start the cascade. The same thing, the same thinking is temperature. We know that if you reduce the temperature, then you have less body reaction, and if you have less body reaction, you have less adhesion formation. So this is a possibility to change the local metabolism and to avoid that the starting up of the adhesions occurs. There are other companies, I cannot talk about those companies because I am not allowed to talk about new techniques and new products that the companies are testing. But there are companies working on the cells that make the recovery after the trauma, and those cells are influenced by products that are working on a cellular level. More, I cannot say more, but this is something for the future. Cellular influence. We are also working on some products. Next slide, please. We started to look at the stem cells, and we started to look at a possibility to take stem cells from the patient, let's say to filter them, and then to bring them back to the place where the trauma is, for example, incorporated in some kind of gel. Yeah. So we thought of bringing in the gel that we are using, but to bring in some kind of drug or to bring in stem cells of the patient, so that there is already a police, there is already a fire brigade that takes care of the trauma on the place itself. We found out that this is perhaps not the good solution. So the next step we are thinking of is to modify, to modulate the stem cells that are coming at the place where the trauma is. We know that if you do a trauma on the peritoneum, then there are stem cells coming to close the wound, to cover the wound. And the stem cells then are changing into mesothelial cells that are the repair of this wound, of this trauma. Now we are thinking about using those stem cells that are already there. So not bringing them inside, like the first hypothesis, bring them inside with the gel or so. No, no. We think if they are already there and we can modulate them with some kind of product, we could stimulate them to do their healing work, but to avoid too much healing, to avoid exaggeration of the healing, and thereby avoiding adhesion formation. We think that those 3 or 4 possibilities is that where we are going in the future. Metabolism, stem cells, microclimate, and of course, not forgetting our gels, our fluids, our shields, and our good surgical technique. Dear Olarik, dear ladies and gentlemen, Dr. Torres and I have given you an overview on pathogenesis of adhesion formation and showed you 3 parts. The past, that is still active, the present, that is still active, and the future, where we think adhesion prophylaxis will be heading to. Thank you very much for your attention.
Thank you very much, Professor. Are there any questions? So please, Dr. Methapan, do you have any questions? And I also saw my mentor, Dr. Kitikan. สวัสดีครับอาจารย์ So, Professor Rudy, can you hear me? I have some questions.
Yeah, if
Yes.
you can translate, then this will be some help. Then we have a good audio transfer.
Yes. So the question is, what is the reason that you will not use the anti-adhesive agent?
So, if you ask me, should we use adhesion prophylactic agents right now? Then I would say we should use them in every surgery we do, because we are always trying to give best to the patient. And trying to give best is, like we said before, good surgical technique, tender loving care of the peritoneum, and using all the products that we have right now. The problem is that not one product is a wonder product. We have no product where we say, use this, then you will have no adhesions. All the products that we test, they have a reduction of the adhesion formation, but there is no wonder agent. This is point 1, the first problem. The second problem is, it must be affordable. And in many countries, the products that are on the market are not affordable or not affordable for everybody. So the answer is, yes, we should do everything we can for every surgery and every patient, but no, we have no product that secures you not to have adhesion formation, and we have the budget problem that we cannot give all the patients that are in need of an adhesion prophylaxis, we cannot give all the patients these products.
Yes, and this is the last question. We know that when we do laparoscope for the endometriosis, there is a lot of the adhesion post-operation. But if we do the total hysterectomy, will you use the anti-adhesive agent? Because there's it's like a radical surgery, right? There's no uterus, no ovary. Will you use the anti-adhesive agent?
As said before, if you have the budget to do it, then use it, because we don't know the biogenetical profile of the patient. So it can be that if you do a total hysterectomy in 20 patients, it can be that in 10 patients you have no adhesion, if you do it laparoscopically. And in 10 patients, you have adhesions. And in 2 patients, you have major adhesions. But we don't know which patients. So if you can afford it, then do it. If you cannot afford it, then unfortunately, right now, we don't have the possibility to give every patient an adhesion prophylactic agent. There are countries where they are giving all patients adhesion prophylactics, and there are other countries where no patients get adhesion prophylaxis, and they only get a prophylaxis when they come back and they have adhesions, and they get adhesiolysis and get adhesion prophylaxis, because then with the adhesion prophylaxis, you are sure that you are treating a patient that is prone to adhesions.
So thank you very much, Professor Rudy. This is very, very informative, and I think all of us are very welcome that you will come to Thailand again.
Yes, I hope I will be able to come back soon to you.
โอเคก็ขอบคุณอาจารย์ทุกท่านด้วยนะครับวันนี้ก็ขอบคุณมากๆนะครับที่อาจารย์มาฟังในวันนี้ขอบคุณครับอาจารย์สวัสดีครับ